you.
Hi, good evening. Thank you for joining us. A lot has happened over the weekend, specifically to do with the new variant of COVID. Many of our cities now in night curfews. We've also had the scientists of the WHO say that night curfews actually don't make a difference at all. So what does make a difference, and how do we keep ourselves safe? How worrying is the spread of Omicron? Remember, the numbers are quite stark in India at this point. We're seeing a sharp spike in those numbers. Mumbai, for example, reporting 8,000 cases altogether, of which Maharashtra reported Omicron cases of 510, and Delhi has reported 351 cases of Omicron. India's total tally is now at 1,700 in the new variant. And India's total tally as a country of all cases together for the last 24 hours was 33,750. Now, we haven't seen numbers like this since the second wave. So obviously, we are in a third wave. What does this mean? To help us answer those questions, I have guests with me right now. Dr. Rakesh Mishra, Dr. Tanmay, Mohapatra, and Dr. Sanjeev Bagai. Doctors, thank you so much for joining us and agreeing to answer our questions. Happy New Year to all of our viewers, and Happy New Year to you. I'm sorry we're not starting on a better note, but I'm going to get straight to it. One of the most common questions we have got on Instagram and on Twitter, Siddhant Banerjee asked this question on Twitter, for example, is about the symptoms of the new variant. We have Rima also, Shetty HR Shukya, who's asked the same question. Does this particular variant look in any way different from Delta? And does it seem milder? Because we're hearing a lot of that. Dr. Mishra, Dr. Rakesh Mishra, I'll come to you first. Is there a difference right now in how this is manifesting in our population?
Yeah, it looks like all the data suggests it's a bit milder, and virus is more active in upper respiratory tract and less in lungs. That doesn't mean it does not influence lungs. And there are few newer symptoms people are noticing, but by and large, it is after all SARS-CoV-2. So I don't see a great difference in the thing, and none of these milder symptoms should be taken as any kind of respite, because this can be actually a deceptive thing. We can't let this infection go even if it is mild, because the virus is constantly mutating. And if we let it play with us, it will come with more troublesome versions, because it has already acquired something which a virus will need the most, which is the high infectivity. That it has achieved the maximum so far. So this I would consider more dangerous, because it is going to be spreading fast, and which also means that it has more chances of making more variants. So that is what we should worry about, even if it is milder, even in a long term. A short term basis looks like less hospitalization, all those things, but long term COVID, we don't really understand. Something which has come few months back, few weeks back, we can't say much. But more clinical and other aspects, I think Dr. Bagai and Mohapatra can put more light on that.
Dr. Bagai, same question to you in terms of the clinical aspects also. Do you agree that it should not be taken lightly? Because a lot of people are saying, yes, the numbers are high, but people are not getting very sick, so it's okay. Is it okay?
Good evening. So I think we've just seen the initial part of just the trailer. So it will be very premature and foolhardy to take this lightly and gauge the entire movie. We know that this is 5 times more predisposing to reinfection, 5.4 times more to breakthrough infection, 8 times more immune invasive. It has 70 times upper respiratory viral load for transmission. It also transmits for 6 to 8 times more than Delta. It's hit children 6 times more than Delta. And more importantly, it's doubling time from international data. It's 1.5 to 1.8 days. So the initial advantage of it being slightly mild is very quickly washed away because it's so highly transmissible. To give you a ballpark comparison, so far the most contagious virus known to mankind has been measles. And through international modeling studies, it has been shown to be as contagious, if not more than measles. So measles will infect 225 people from one index case in 20 days. This has a predisposition to infect more than 1 lakh. So the advantage of it being slightly less in terms of lung involvement is washed away by sheer numbers. So more number of people who get infected, just a small statistical percentage of that, also if they get significant lung infection or involvement rather, it would be catastrophic for us. There are two kinds of data which are shown, the South African data, which has shown a slight decrease in numbers, and they have shown almost 84 to 87% decrease in admissions as compared to Delta week on week. This paper has been published today. It's still to be peer reviewed, but it's been published today. The data looks very strong. And on the other hand, the European and the American data shows a graph which is going just sky high. This is just bursting out of its seams. And a lot of patients are being admitted. A lot of them are being ventilated. A lot of them are dying. So like I said, it's in the early stage, but from a medical point of view, a genomic point of view, yes, it is predisposed to be a little less lethal because it's not following the classical serine pathway as cell entry. It's not following the TMP-RSS pathway. These are the cell receptors. So it's hijacked the cell to go through the endocytes. So it's tricked the cell to enter the endocytes. And at the present moment, that what we know is that the TMP-RSS has a very high representation and expression in the lungs and less in the upper respiratory tract. So that's the reason it's hitting the upper respiratory tract more. There are studies from Belgium, from Danish study, Cambridge, from Imperial College in London, Hong Kong University, to show that it's less in the lungs. From involvement of the lungs, Delta was 250 times more than the original one strain. This is supposed to be 10 times lesser as Delta, but important enough not to keep our guard down.
Is it also fair at this point, Dr. Bagai, to say that since we don't know how this plays out, we don't know what lasting impact it will have on our body for people who get Omicron, for example?
Yeah, so I think all the strains, they've in fact done this study also. I don't think any one of us has read as much even in the MBBS and MD and DM days and fellowship days as what we are doing now. But having said that, it's very clear that the strain of the virus is not determining the long-term side effects. What really the SARS-CoV-2 as a genomic code is doing is it produces what we call as autoantibodies, and they're long multidimensional meta-analysis studies. So the autoantibodies are very much like mimicking autoimmune diseases like SLE and mixed connective tissue disorders, which are pretty nasty. And apart from that, it bluntens the interferon pathway. So from that point of view, long COVID is a well-known thing. It ranges anywhere in long term up to a year onwards between 15 and 20% of patients. But between 3 and 6 months after recovery, almost 84% of people. And about 9 months down, it's about 50%. So a lot of people are out of work. They have what we call as chronic fatigue syndrome. They have myositis. They have cardiac involvement, neurological involvement. And very surprisingly and very annoyingly, even mild asymptomatic small infants, and the smallest case report is of a 6-month-old. No one knew that the child was contacted COVID. The parents didn't know because the child externally was healthy. And 9 months later, this child had a demyelination of the brain and the spinal cord, and now is not looking good. So we need to keep, I mean, as the bottom line, we need to treat this virus with a lot of respect.
Very well said. Dr. Mohapatra, the symptoms, is it the same symptoms with the new variant as well? Is it fever, sore throat? There's some question about the lack of taste and smell. If that persists, how do we know? What should we be looking for?
Honestly speaking, we don't have enough data to say that there is any difference in initial symptoms regarding the presentation of Omicron as opposed to other variants. This particular aspect of it is being kind of less severe or that kind of thing. It's too early to comment on that, and that's why if somebody had this milder symptoms and ultimately kind of relieved with that. That can be Omicron. That kind of statement doesn't help any clinical presentation or any clinical treatment. So any kind of sore throat, fever, loss of taste and smell, those kind of things right now, better to be considered as Omicron, if not other COVID ones, because the rapidly it is spreading, it's very likely that it can actually replace the Delta variant. And there is a likelihood that the current driver of the pandemic may be totally replaced through this process of spreading of Omicron right now. But we should be actually following the same kind of things that we have discussed since 2020 early days, January onwards. And right now we know that it's not only the personal protections and all other stuff. We need to pay attention to ventilation. This is very important right now, as well as the community awareness. And like there is, it's a very thin balance. If we talk about its severity, we may end up in causing a panic kind of things, ultimately overwhelming the health system, where maybe the appropriate triage to have the more severe cases may be jeopardized. Whereas the kind of situation that we are seeing, I traveled in last few days and I saw whatever we discuss, whatever is there on the news or something, use of mask and it's kind of the awareness or something, it's non-existent almost in different parts of the country. Yeah. And that's why we need to expect that. We need to be cautious. And if not, we're going to have another menace on the cards.
And this is really worrying because over the weekend, we saw visuals come out of Goa, for example, we saw kinds of crowds that should not happen, even if COVID was not a problem. It was just ridiculous. And most people have gotten accustomed to wearing their masks on their chin. There's no social distancing. Public transport is full of people. Markets are full of people. We've really, really let our guard down. We are also having election rallies in 5 states. It shockingly looks like we're repeating our mistakes from last year, from exactly a year ago. Dr. Mishra, we've had some state governments now announce night curfews. They're closing gyms, they're closing some salons, things like that. Is any of this effective?
Well, people who go to gym and all, probably they are health conscious and they will take care of themselves. To me, night curfew is absurd for us because there is not much of in winter, particularly where is the night activity? If at all, maybe it has some positive, some psychological thing that there is something, let's be careful and all that. But I don't think that this will help in any way other than the psychological way that people wear better way, the mask and so on. But I don't think otherwise, as a policy, this should be emphasized. We should straight away go and try to minimize the density of people in any working place, reduce somehow. I mean, you have a night curfew, but you have cinema hall running house full. I wish I could go and see 83, but I'm avoiding. So what we are talking about, and in cinema hall, you see 6 inches away from next person. And so we are inviting this virus. The virus, whatever, any virus, not forget what they want. Any virus, which what they want means what the selection pressure of the virus is, that increase infectivity, and it should be able to fool the immune system so that it can go to the same host again, and vaccine breakthrough if you are providing vaccine. So these are the symptoms are secondary. Virus doesn't care whether a person dies or falls sick. Virus just wants to go to yet another person. And this virus has achieved that to the best possible way. It's most infectious so far that we have seen. You just heard Dr. Bagai say that it's probably one of the most infectious viruses. So now, if in the process it acquires something which troubles us in short term or long term, we are going to be in big trouble because a huge number of people are going to be infected. Although the virus selection pressure is based on infectivity and vaccine breakthrough or immune escape criteria, we can prevent it can happen only if virus is able to reach the next person. If the virus doesn't go to the next person, it's end of the story, however potent this virus may be. And we are now promoting that, whether we are doing election rally, whether we are having restaurants. I mean, night curfews may be effective in the West, where there is a lot of pub life and nightlife and so on. We don't have, except maybe bigger cities in certain parts. It's not much of a thing in a traditional or smaller cities. So what we have to see is the staggered timing of the working, so that at any given time there are lesser number of people. So I would say the other way, you just extend working hours late till night, so that the lesser number of people are there at one given time in a working place, so that work goes on, because we can't imagine a shutdown. A shutdown will be simply disaster. We will all be very happy sitting home, happy or unhappy or whatever, but the poor people whose daily wages are their breadwinner for the family, it's just, I don't want even to discuss that. It's so disastrous. So to avoid that, we have to keep the spread of the virus in check. And the only way to do is to not to do any rally, not to do any. I was really surprised to see the news. I don't know whether it was correctly put that Election Commission thought that in UP Omicron has not much effect. Who is advising?
Dr. Bagai, I want to pick up this election decision right now, because the Election Commission has decided to go ahead with the elections and has advised the chief secretaries of these 5 states to speed up the vaccination process in these states. Is this adequate, or is this a mistake in your opinion?
Sorry, can you repeat your question?
The Election Commission, Dr. Bagai, has decided to go ahead with the elections as scheduled in 5 states.
Yeah, so it's looking London, going to Tokyo and landing up in Siberia. It is unscientific, it is illogical, it is bizarre, it should never happen. In the ideal case scenario, I think the elections could have been postponed by a period of 6 to 8 weeks. We would have had more breathing time to understand this strain's trajectory a little better. That's the first point. Plus, we would have given ourselves breathing time that in case there is a deluge of patients, we are infra ready. Point number 3 is, in case you have to go ahead with elections, I think rallies are a passe. They're a old, I mean, they belong to the Archaeological Survey of India. No one wants it. It's a paid for gathering of herd and sheep and cattle. It is so illogical to have these kind of crowds gathering. So I think the polling can happen, but preferably a couple of weeks later. But I don't think that's the way it's been decided. But the polling should have been stretched over more number of days, more number of booths, called in a staggered manner, few in the morning, few in the afternoon, few at night. There are 3 or 4 very important points which I want to make. I think India is one amongst the best countries for pushing the vaccine campaign. I must give full compliments to the government. There is no other country which has finished 90% first vaccines and 66% second shots. We've even outpaced US, which is 1/6 our population size and 5 times the infrastructure and vaccines to waste. But having said that, what we really need to do is we need to pay a lot of attention in the following points. One, we need a very good and a judicious mix of rapid antigen tests. We are not doing this at all, and I think it's a big, huge mistake. We are relying on RT-PCR, which the peak sensitivity is only 67 to 83%. The rapid antigen, the new ones, which are called as quantum rapid antigen and lateral flow antigens, are giving a sensitivity and specificity close to 94 to 100%. Point number 2, these tests pick up the people at the infectious most and approximately 24 hours even before the symptoms begin. So you are catching a person potentially who is harboring it, but not testing positive through other ways, but is still transmitting. So you are breaking the chain of transmission. Point number 2, the night curfews and things are completely, they belong to the relics. It doesn't work like that. I don't know who's advising, but I'm sure whoever is advising should take a relook at the medical science. What we really need is crowd management. You're putting a 50% occupancy in the restaurants, but there are 400 people waiting outside for a table. You're putting a restriction on 50% capacity on a bus, fine, okay. But then there are 200 people, one on top of another, waiting at the bus stop. So it is being counterproductive. It's like wearing a shirt without trousers, but with a tie. It doesn't make any sense. It doesn't work like that. It's a feel-good factor. You're trying to put a band-aid on a gangrene line elsewhere. The last most important point is we need a national policy on ventilation. I've said this at many forums for months together. We have to, that's the buzzword for the next 10 years, is ventilation. In this, Faye, just last 60 seconds in this, what I want to say is, we know that this is an airborne transmission. Okay, I think WHO and CDC faulted very badly for many months last year and year before last, saying it is droplet infection and XYZ. Without going into the fallacies, the point is this is microaerosol, it is airborne transmitting, and now this Omicron is hugely transmitting. Winter months in central and northern India, it transmits it twice as much more. Pollution makes it transmit even more. And more importantly, last year we heard of something which was called as long jump COVID. Beautiful article in Lancet in which it mentioned long jump COVID. Means it can go from room to room without a person actually leaving the room. That is through the AC ducts and vents. That's why ventilation policy is so important. This year, now it is called as fly COVID. That means it can go not only room to room, but corridor to corridor and from one end of a hotel or quarantine to another without the people leaving the room. The level of exposure is 3 to 5 seconds. That's all what you need to contact this. Therefore, masking is important. Crowd management is extremely important. You're just attending to one half of it by saying, don't overload a bus, don't overload a train, don't overload a restaurant, but there are enough people outside. So I think the night curfew should stop immediately. We need a proper rationale of working hours. I think overall, India should pass a rule that people should have 2 shifts of work. And it's rotated so that there is no monotony as such. So people can come from 8 a.m. to 2 p.m. very much like other people do. And people otherwise can take an evening or a night shift from 2 p.m. to 10 p.m. Point number 2, there should be a complete policy of at least 20 to 30% of the people can permanently work out of home. You don't need the people to actually come into the offices. And last, most importantly, is public transport needs a huge address. I think we've been talking about it for far too long, but I think these variants which have come in is not only a wake-up call; it's really put us flat. So I think we need good, sensible people in correct positions. The states must have a unified policy. Reporting must be good. The stigma of COVID must go away. Public awareness must be huge to let people address it and come forward to get themselves tested. Can you believe 68% of children have underreporting because they never got their children tested? Worldwide data from CDC. In India, we wonder that the full world is showing a 3 to 6 fold, that means 500% more increase in pediatric cases. India, we're not seeing this. The reason is we're not testing enough in children. And children who are being admitted are being labeled as wheezy bronchitis, bronchiolitis, respiratory distress, and what have you, but those kids have not got the COVID test done. So you can't label them on the discharge summary. So I think there are many points to address, but what we really need at the present moment is public awareness and a lot of common sense. We need to address the core problem. Core problem is crowd management and ventilation.
Very well said. Most of us will remember actually in the first wave, we were sanitizing every tomato that came into the house. We didn't really know how this thing was actually moving. There was this assumption that if you were in the presence of a COVID positive patient, that was sure death in some way. We've learned a lot more, and we understand now that if you are in a closed space, especially air-conditioned space with other people, that is really trouble. So ventilation of our spaces, and we've seen a lot of this right now, during the festive season, malls, for example, have just switched off the ACs. But that air is not going anywhere. It's still there. Those rooms are not being ventilated. People are just sweating now in close quarters, which could possibly be that much worse. We have other questions as well. Dr. Mohapatra, a question for you. Yes.
Can I just add one small line in this?
Yes, Doctor.
65% of overall transmission is indoors. And it's a shame that we've not addressed indoor transmission as vigorously. And we can't, it's not just keeping windows open. It's a full concept. It's an engineering, scientific concept of ventilation. Point number two, very importantly, is any unvaccinated child or adult in an otherwise vaccinated family increases the fold of household transmission 14%, and multiplied by 2 or 3 people unvaccinated, like vis-a-vis children, your risk of household transmission increases 54%. So doing one and not the rest means you're still transmitting indoors, and ultimately these people will go outdoors and transmit it again. You can't douse a fire in a building in one room and come across as heroes saying, I have controlled the fire. The fire has to be controlled on every floor, every room, every corridor. Only then you can save the building.
Very well said. I also understand, Dr. Bagai, that you have to leave at 8:30. I thank you for your time, sir. And
Are you asking me to leave?
no, if you can stay, we would be very happy to have you.
Okay, 5 minutes more.
Okay, fine.
Please go ahead.
Aman Peshawari asks a question. He says, what is the expected projection right now for this particular wave to peak? Are we comparatively ready for a disaster in comparison to the second wave? I'll take this question to Dr. Mohapatra. Dr. Mohapatra actually works with the Maharashtra, COVID cell. He's sitting with governments on a daily basis, advising them. Are we better prepared now this time?
So regarding preparedness, health system may be better prepared, but its implementation, we are not always sure, because implementation ultimately happens in the presence of accountability. And we are not sure individual accountability, system level accountability, where we are actually presently, because if you are that much accountable after all the vaccination efforts, we would have actually had everyone vaccinated by now. And also the vaccine hesitancy and other stuff wouldn't have existed so far. We are actually still talking about a lot of this conspiracy theory and other stuff, even at the system level and other aspects, but we are not ensuring that every human being in whatever status they are have the access for the vaccination. So regarding preparedness, definitely we are better prepared than first wave, better prepared than second wave, definitely. And in the current scenario, it's too early to talk about projections and other stuff, because given the growth rate that we are seeing, it's actually, and given the current testing scenario and the take it easy kind of attitude in the community as well as system, I'm seeing in different forum, also in the medical forums, also discussion about overloading the system unnecessarily at things like that, when we are actually worrying about long-term COVID antibodies, all those stuff. So given all this awareness, there is a likelihood that we are going to see the exponential peak as soon as we are starting to do more meaningful tests, as Dr. Bagai was mentioning. And given the fact that whether we understand or not, third wave is happening, and whether we capture that at the exponential level or not, it is happening exponentially. So given that there is a chance that this particular wave may actually disappear early, but that may not be true if we have different strains continuing at the same time, and which is different strains and variants, continuing at the same time. And that's very likely this time. So, and we have already discussed about the season. It has happened in a very bad time when spreading of the virus is much easier. It's common. Before COVID also, we used to know that this time of the year, this January, February, March, this is the time when we have other viral diseases also increasing, pollution level, etc. There are several other things. And there is another additional worry about ventilation right now, that is cold. Because of cold, people generally close all the avenues, if they have, of ventilation. And this is actually going to impact the indoor transmission much more. And we are not at all aware about the actual meaning of the word ventilation. You already spoke about the switching of AC means improving ventilation. Horrible. So the point is, given all these, we are not right now in a position to talk about projection. System is better ready, but the accountability needs to be more. And this accountability is bidirectional. It is not only for the doctor or healthcare providers. It's the social accountability of each and every individual. If I am unnecessarily panicking, or if I am doing something even gathering and all of the stuff unnecessarily, that means ultimately I'm causing trouble to myself also and definitely to others also. That's why I spoke about this from the start of the discussion on COVID, that we need to generate a community response strategy. We need to have a community sensitization and awareness. Only some voice in the collective is doesn't going to help. We have to have some continuous messaging through all the civic bodies, all kind of medical awareness generation system, so that general people understand the difference between being cautious and panicking. If we can do that properly, we can handle this epidemic, this particular wave, better than before. And still, we have to be very cautious about what we see till March 2022.
And here's my question to the entire panel. Do you foresee lockdowns?
I don't see.
You don't see full lockdown?
I don't see full lockdown. First of all, this question is what I see logically or what I see as a speculation. So logically, there is no point in making countrywide lockdown or that kind of thing. Rather, we need those small cluster level targeted approach. But regarding even from government decisions and all of the stuff, I don't see full lockdown, full shutdown kind of thing. But definitely, there is a requirement of making some logical decisions. I really don't understand. I just read that there is lockdown as well as there is night curfew, as well as you cannot travel even in your own car. I really don't know what does this mean. So anyway, we need to have logical things like, as we have already discussed, Dr. Bagai has mentioned all those comprehensively. What does really this mean that when half of the shops are open, half of the buses are plying, half of the half of the seats will be vacant, and when we are having one person on top of another for the waiting space. So ultimately, if we can reduce the need for that travel, if we really make India a digital India to ensure that we can actually have different access to different things sitting at home where we don't need, and the shifting of duties, sharing of work, convergence across different departments, if we can actually do this kind of HR rationalization in different offices and other stuff, and wherever we can actually monitor work progress virtually, if we can actually ensure that work from home, then we reduce the requirement of gathering and travel. An election rally, religious things, I don't know. I mean, we should at least learn from the virus if we cannot learn from ourselves.
That is true. One would have assumed that we learned some hard lessons from about a year ago during the second wave, where we had large gatherings that were religious, they were political, they were for all the wrong reasons. And it then led us down a very deadly path where so many families lost their loved ones. We should know better than that. I want to read out some of the responses we're getting from a viewer called Anand. And the reason I'm bringing this to you, doctors, is because this is the sort of thing that we should be worried about. Anand says, and I quote, Omicron is not dangerous. Government is overreacting and harming people's lives. He goes on to say, a study conducted in South Africa says that Omicron can actually protect you from the Delta variant. The antibodies by Omicron variant will neutralize the Delta variant. And he goes on to say, even in a peak of the Omicron wave in South Africa, half the hospitals remain empty. Now, it's this sort of, and this is what I was talking about in the beginning, this sort of, even if you get it, it's not so bad. So let's not stop moving around and working and doing our thing. Let's continue to live as normal. How dangerous is this sort of thinking, Dr. Mishra?
This is suicidal. There is a difference in natural immunity that we acquire by natural infection and vaccination. And even many learned people have been saying that this is a blessing in disguise and so on, that it will infect and people get immunity and all. Please remember that vaccines don't create new variants, and every infection has potential to create new variant. We are giving a virus a chance. So don't take it lightly that virus is mild. This mild is, as long as it is infectious, this is dangerous because it can bring trouble to us. And it is not going anywhere else. It is still in our respiratory tract, upper and lower and lungs. Even if it is less than Delta, it's 25 times more infectious in the lungs than the initial variant which created the pandemic. So we are joking if we are saying that we are safe with milder versions and all. If we may feel consider we may consider ourselves lucky that there will be not much hospitalization, but the number is what we have to worry about. Even if it's 5% people need hospitalization and its infectivity is this kind of dramatic as we are talking about, we can still have people suffering for getting a bed or and leave aside the new variant that will emerge from this. Each infection creates a chance for the virus to make a new variant. So we are helping the virus if we are being kind to the virus that, okay, come and infect and immunize me. That is not, is not any other infection. This varies, variation and so many variants. We already seen the mutability of these viruses are what is makes it difficult. I mean, we are so lucky to have vaccine. We should make use of that and depend on vaccines rather than depending upon natural immunity. I mean, we get natural way, we have protection, that is one thing, but that should not be our strategy. It's completely misleading and being stupid to think that this is mild virus and so we can relax about it. We should be more careful because it can be, we may have to pay very heavy price later.
Dr. Bagai, we have a question from Praveen Ganesan who says, Dr. Bagai mentioned antigen tests are more sensitive than RT-PCR. Can you please elaborate on that? And I also want to ask you about booster doses. Do you think that India has made the right decisions at this point to offer booster doses to those who are vulnerable, aged, healthcare workers and children? Is this the right way to go?
Yeah, so first and foremost on the rapid antigen test, I think the rapid antigen test we spoke of sometimes in middle of 2020, and then those generation of tests were not very good. They were like Maruti cars, and now we have a Ferrari in the same make. So much has evolved. So I think we need to keep pace with that. There are 7 different types of RATs, and they have shown a huge impact. In fact, at a point of care, rapid antigen tests, there are studies to show that if you use them for mass gatherings, they've done it as a study in a concert in which they have picked up 13.8 cases per 100 attendees, which were innocent asymptomatic carriers. So rapid antigen test is here to stay. We only have to open our eyes and read some literature. Point number 2, with regards to boosters, it's a no-brainer. The third vaccine dose, in fact, should not be called as a booster. It should be called as a part of the primary immunization. I've never seen anyone call a third vaccine of hepatitis B as a booster. I've never heard anyone call a HPV, human papilloma virus for cervical cancer, as a booster. And surprisingly, we give 6 to 8 doses of polio, and we don't call the number 3, number 4, number 5 as boosters. It's a part of an immunization regime. When you put a booster, you're putting a stigma in it. Should I take it? Should I not take it? And more importantly, the flip side of the coin is people feel, the booster is there because the first 2 didn't work. So let me tell everyone that the first 2 doses have worked. Whoever have taken it, even the first shot, whoever have taken is working and has worked, because you develop a cross-reactive tissue T cells, what we call as resident T cells, which are your memory T cells. Without going into the micro details, there have been studies after studies. Lancet has compared 8 different platforms in 18 different permutations and combinations. Lancet again has compared a study which has shown Brazil versus Scotland of 42 million patients, which have shown decreasing immunity. And an all-cause meta-analysis, which has come out this week, is shown that 2 shots, 5 months later, your immunity falls to 52% as far as your vaccine preventiveness is concerned. Third dose pushes that up to 88%. Rockefeller University, there are 3 studies from Israel. There's a study from Portugal, from Qatar, Kaiser study, British Medical Journal. There's a series of them, more than 85, 87 of the studies internationally. To cut a long story short, your immunity falls 180 folds down at the end of your 5th to the 7th month after your second shot. The third shot pushes it 200 times more up. So it makes sense. It's a part of an immunized response in the body. I want people to understand that immunity is not something as a switch on, switch off. It's not a turnkey. It's a biphasic mechanism. You have 4 different arms. You have a B cell, T cell, adaptive, and innate immunity. Your main memory cells are your T cells, and your B cells. Your production house is called as a germinal center. Your germinal center is only kick-assed to produce long-term cells with your third dose. So your third dose is important. Mr. Modi Honorable PM has used it very, very carefully. And I must give full compliments to him. He's used the word precautionary, right? He's used the word carefully as a third dose, not calling it a booster, neither a third dose. But I think the healthcare workers, because we are continuously exposed to it, definitely require it. And hopefully from 10th onwards, we would be in a position to get it. The only thing, alas and amiss in the Indian scenario, is that I wish we would have got a mix and match trial data in the Indian scenario much earlier. It is still lacking. Sorry, and this should have started sometimes around May, June last year, so that by October, November last year, we should have had at least a 4-month collaborative data. The clinical data, which is available in Indian scenarios, have 146 crore injections. It's like vaccinating US many times over, complete Europe and Australia upside down 3 times over. You have the clinical data. All what you need is a good data analyst to put in the numbers and see what your immunity is.
So what you're saying, Doc, is that for those of us who have received Covishield in our first 2 vaccines, to be able to tell us whether the third dose, whether that is booster, precautionary, however we want to call it, should be Covaxin, should it be Pfizer, can it be Covishield again? We've not studied enough.
Yeah, so just to complete, this is as educated and authentic a medical suggestion, because we don't have the data in the Indian scenario. I would go ahead with the same platform. If you're taking 2 AZ, take the third AZ. But having said that, the other side of the coin is Covaxin is a wonderful platform. And my own hunch, gut feeling is that 2 AZ followed by Covaxin would be a completely wonder combination. But I can only say it medically, authentically, if we have the data. And the reason is that the scientific platform, although both are vector-based platforms, the Covaxin covers the N-terminal domain. This is where the mischief is being done by Omicron. It's at the N-terminal domain. And the ORF platforms, they're different parts of the protein. Since this is the whole viron inactivated vaccine, it will presumably work very, very well against Omicron.
Well, speaking of Covaxin, there's a very worrying story that has come out today in both in India Today and in the Business Standard. I just want to read it out. It says, Bharat Biotech starts picking up unused Covaxin stock from hospitals and relabeling them to extend the shelf life. Now, we know that the vaccine had a 12-month expiry date. Apparently, there are large stocks available at private hospitals that have not been administered, that are fast approaching that expiry date. Bharat Biotech is going to pick it up and give it new labels with a refreshed expiry date, which will be used to vaccinate. This is according to the India Today. It will be used to vaccinate those between the ages of 15 to 18 in the new drive that has just begun today. Now, I'm not an expert here. It makes me nervous to hear this. Is this something I should be worried about, Dr. Mishra?
I think it's a matter for police investigation. I don't think we can discuss about it. Taking a while and changing the date. I mean, I don't know. I hope this is.
Faye, can I beg to take your leave?
Yes, go ahead. Yes,
Thank you.
You could comment on this story.
God bless you. God bless you. You want my comment on it? As soon as my colleague, Dr. Mishra, has mentioned the word police, I'm running. God bless everyone. Keep safe. Keep safe.
Well, thank you, Doc. I'm going to ask Ira to also share this on the screen so that our audience can see the story that I'm talking about. It's in 2 different publications today about the fact that Bharat Biotech apparently intends to relabel some of the stock. Let me rephrase the question, Dr. Mishra. Are there tests involved? On what basis can the expiry date of something that was manufactured a year ago be changed?
See, the expiry date, you say that if it 6 months you have tested and it is fully active, so you can say it is safe for 6 months. Beyond that, you don't know, so you can put that as expiry date. I mean, to give a benefit of doubt, if this report is correct, that maybe they tested that it is stable for 1.5 years, and then therefore, if it is being stored in appropriate way, it can be used for another 6 months. But I would say that if that is the case, they can just issue that vaccine is stable 6 months more rather than bringing the vial and changing the label. I'm not sure if it is a legal practice to do, but I really don't want to comment too much because I hope there is some misinformation here, and because I don't think a company of Bharat Biotech status will do this in this blatant way and take the vial and change the date. Simply changing the date means you have to change the label, which is technically quite a challenging thing because you have to remove the label, put another one. These things are made in a very automatic way. So I doubt if it is, but even if vaccine is more stable, it can simply be said that you can use it 6 months beyond this expiry date and we guarantee that it is good. It's as good as going and changing, labeling. This costs money, time, effort, and suspicion.
In fact, let me ask Dr. Mohapatra another question, which might be slightly difficult to answer. Dr. Mohapatra, we know that the resident doctors are on strike. They're on strike because their postgraduate admissions have not been processed. So we have an entire batch of doctors who are sitting at home because their admissions have not happened. Now we're going into another wave. We've been warned by WHO that this is going to put pressure on our healthcare system again. The junior doctors in our hospitals are currently at 66% strength because that one batch, out of 3 batches, 1 batch has not come. Batch number 1, year 1 has not come because they just have not been given their admissions. How difficult and unreasonable is this going to be if we see our hospitals fill up again?
It's quite unreasonable, and that's on the part of the system. If we need our doctors to be on the work, the junior doctors must not have gone into strike without any reason. There must be some reason. I think this particular emergency situation, it's an emergency. And in this emergency, nobody wants to sit at home if they are doctor, if they have taken the Hippocrates oath. The point is to have them in the hospital. They also have some demand, and government needs to actually pay attention to those on war footing and getting onto the negotiation platform right now. Now means now, and then get them into work. So it's not one-sided. It's not, the way we should actually always address these things, that it's not always kind of stigmatizing some profession or something that somebody wants to sit at home and that's why they're on strike or something. Everybody has a demand, and that demand must be of logic. Otherwise, a group of educated people don't go into strike. Now, there must be some optimization in that, and every problem actually has its own solution. We need to find that out as soon as possible, because definitely we need more people at work for the provider side, because this is not only for the general population or something, this is for the doctors also, because then only one doctor can have less exposure if they have more in their pool. So it's a collective problem. And again, I always said this from day one, that we need to learn when virus is changing colors, but changing all their everything that they can, and ultimately coming in vaccines and variants, we are having our problems unchanged since during last years. So we need to pay attention to our providers. And just like when we are talking about this third dose, we need to ensure that our providers, as well as the, healthcare providers, I'm not talking about doctors, I'm talking about everybody who can come into contact of a patient. And it should be also directed by the day of vaccination of the second dose. Both together we need to pay attention to and optimize. It's not always only for elderly or only for those who are sick. Yeah.
And finally, gentlemen, my question to the both of you is, obviously, individual citizens need to be doing whatever they have to on their own level to make sure that everybody is okay. Is it the same thing? Dr. Bagai put it very well last year, where he said SMS, which is sanitize, wear your mask, social distancing. Is that still the mantra? Even in the new variant, whatever variant might come our way, these 3 things is the way to stay safe. Dr. Mohapatra, you first.
I said 5. These 3 definitely. And then comes ventilation, and then comes common sense.
My father would always say common sense is the only sense that's not common.
Yeah, it's the most uncommon thing on earth.
Dr. Mishra, your advice.
Yeah, I always say that to my students, and that's the most important thing right now.
Yeah, absolutely. This is, after all, SARS-CoV-2, it's just more infectious. So methods are the same. If you wear mask properly, and as you know that now you have less time to relax, so you have to keep the N90. Now I'll recommend either use N95 or double mask yourself with surgical. We have been saying in the first wave that don't use N95, use cloth mask and those things, because those were in short supply those days. Now we have enough of them. A lot of we are even exporting such things. So we should use the good mask and never touch or remove the mask. They should be taught. There should be teaching how to wear the mask, and not putting on the chin or removing, just covering the mouth and nose is open. And people are touching and adjusting 20 times when they're talking to. Many of them, to take a selfie or to, when they want to speak, they remove the mask and start speaking. So these things should be practiced. And as I said, the virus will spread only if we allow it to spread. And if we allow it to spread, even if it's milder, you are giving a virus one more chance to become new variant. So we are responsible. People are responsible. Some are unknowingly, some are being lazy, some are being careless. And so few things that even if you have been vaccinated, wear the mask, because that doesn't prevent you from spreading.
Yeah.
And even if you have got the infection, wear the mask. Don't assume that other person is tested negative, so therefore you can be safe. Nothing is safe. So the moment you are stepping out, wear the mask so that you hit the virus what it needs most, that is to use you as a vehicle and reach to another person. So this is something important. Go close to unnecessary person and close space. I mean, almost a year back, we have even published this, that this can spread through air for several feet. It's not just 1 meter, 2 meter. In closed space, it can go to 20 feet. Those variants, this probably will be more infected because lesser quantities required. So methods are the same, but although we are not behaving that way, but we should be more careful because this is more infectious, is what the message is. Otherwise, it is SARS-CoV-2 after all. Then nothing changed. If we are more careful, we can manage. We have advantage. We have very high seropositivity. We have tremendous vaccine drive already in place. Those are our advantage. But if we relax and let the virus play with us, it will create trouble and we will be in difficulties.
Dr. Mohapatra, quick question from Aman Peshawari. He says, India today has reported Israel's first case of florona, which is COVID and influenza together. Will we ever see the end of this? It's obviously a question of, is this the new normal? Are we always going to, every winter see a new variant, have to go back into our houses again? Is there ever going to be an end to this?
Probably not. And when I say probably not, I am not talking about Corona, Omicron, or Florona. Since the history of life, we have virus, bacteria, mammals, and other species living on Earth, having Earth as a planet. And this ecosystem will continue forever. Now, as one human being causes harm to another human being, some virus causes more harm to other species like human being. We have to be pragmatic, that we have to be careful, that we embrace the good ones, like the good bacteria that we have within our stomach. And we have to carefully avoid the exposure to bad ones like Corona. If we talk about the philosophy of viral fitness and all those stuff, a virus don't want to kill their host if the virus is intelligent. And that is always have been seen that over time we get less virulent variant of the similar virus. The expectation of the medical fraternity, it's too early to comment, but still the expectation of the medical and researcher fraternity is one day a milder variant of Corona will replace its severe variant. Probably we are seeing the start of it, but it's suicidal, as Dr. Mishra has said, to talk about that right now. The point is, we have to carefully and patiently wait for the day to come when we can live in a situation without a mask, and Corona, Florona, or some variant of this will be also living somewhere without harming us. How that can happen? the ontogeny repeats phylogeny theory will take care of that.
All right, doctors, thank you so much for giving us your time. It is always a pleasure to speak with you. Also, I think all of my audience joins me thanking you and your colleagues in the medical fraternity, the nurses, the ward boys, the people who come in to clean, the junior doctors, the senior doctors, for the work that has been done over the last 2 years, and express our solidarity for the work that is going to need to be done for the year that is coming as well, because obviously we're not at the end of this, nowhere close. So thank you for the service that you have rendered to our country. Thank you in advance for the demands that we are likely to make in the year to come as well. For our audience, if you have more questions, write to us on this video, and we will try and reconvene this, this group of people so we can get you the answers. Stay safe. Stay at home if you can help it, and avoid large gatherings. Remember, sanitize, wear your mask, maintain social distancing, stay in ventilated places. If you're meeting someone, you have to meet someone, meeting them outdoors is perhaps the best option with your mask on. Thank you so much for watching. The news is up at exactly 9 o'clock. Thank you.